So this section is on mental health literacy. I'm really, really excited for this section. Dr. Julia HEWS-GIRARD is an assistant professor in the Faculty of Nursing and a professional practice lead in AHS. She completed her Ph.D. at Queen's University and her postdoctoral training at the Cummings School of Medicine in Calgary. Her research focuses on improving access to and delivery of acceptable mental and physical health services for emerging adults. A significant focus of her work is on measurement, particularly the validity of screening tools and the impact that individuals' understanding of the concept of being measured has on the results of these tools and the way in which programs, care, education, support are evaluated. She's currently leading several national studies investigating validity and understanding of several commonly used screening tools amongst post-secondary students, and a multi-site study investigating the understanding of self-compassion scale among women and girls. Particularly interesting. Any research with women and girls, I'm all for it. Other areas of work include program evaluation, peer support, and nursing practice. Dr. PEDRO specializes in leveraging advanced digital health technologies, including large language models, machine learning, and mobile wearable devices to improve healthcare outcomes and patient safety. So he received his Ph.D. in Public Health Sciences from the University of Waterloo and his Master's in Computer Science from the Catholic University of Rio de Janeiro. He's currently an assistant professor at the University of Toronto and a scientific associate at the Center for Digital Therapeutics. And I think we've already touched on the role of internet, social media, AI. We've all talked about the chat programs, and I think this is particularly relevant, and I'm really excited to hear what they have to say. Sorry, I'm losing all of it.
Okay, we'll see if I can work this. Thanks so much, Karen, for that lovely introduction. You're on that study with self-compassion. I've roped you into helping me out, and that study is actually very nicely funded by the Canadian Hemophilia Society, as we're looking at women and girls with bleeding disorders and individuals who menstruate. Okay, I have no idea how to, oh, look at that. So I will preface this by saying public speaking is not my favorite thing. It's a necessary part of my job, so I tend to talk fast. My hands go flying, so I apologize in advance if I hit something or you can't hear me, just wave or something like that. I have no disclosures, although I do have some honoraria from Takeda and some research funding from CSL Behring. So I really like this quote, and I was hoping I'd have, oh, there it is. Wait, just a minute. So it is easier to say my tooth is aching than to say my heart is broken. And so one of the things when we talk about mental health literacy, that we find is that stigma, whatever reason is out there, it's hard to talk about your mental health. It's a heck of a lot easier to start the conversation when we say, how are you doing? By saying, oh, my knee hurts, my ankle hurts, I got a headache. What helps to get into the mental health then is, oh, can you tell me a little bit more about that? But this one I really like. Oh, go. So quick set of aims for my talk today, talk a little bit about context, put mental health of individuals with hemophilia and other bleeding disorders into the context of what we know about mental health globally. We'll talk a little bit about what is mental health. I'm a mental health researcher now, thanks to my postdoc. It took me a long time to distinguish between what exactly mental health is and what a mental health diagnosis is and what that meaning is. And we'll touch a little bit about kind of the common question that we hear is how do I know what I'm supposed to be doing or how I'm doing? How am I supposed to deal with this? I may not want to talk about it, especially in my world with emerging adults who are teenagers mostly. I don't want to talk to anybody else about it. What am I supposed to do? How do I know how I'm getting better or when I have to actually connect with somebody to talk? And then we'll talk a little bit about what support looks like in the world today before I hand it over to Pedro to talk about AI support. So a little bit about context. Canadian-wise, we know, so the 2012 mental health survey for the community mental health from Statistics Canada, that was the last time it was redone in 2023, but it hasn't been analyzed yet. So you can see there that 12-month prevalence is about 4.7% for depression. Lifetime prevalence, which means any diagnosis at any point in time in your life, is about 11%. Females, individuals who identify as female, experience about 2 times more depression compared to males. When we look at anxiety, the 12-month prevalence is a little bit low, and this is anxiety symptoms, not necessarily a diagnosis of anxiety. Lifetime prevalence is a little bit lower than depression as well. And again, individuals who identify as female experience about 2 times more anxiety compared to males. When we talk about younger populations, we know that about 1 in 7 of those kind of emerging adults, youth and emerging adults, experiences a mental health disorder globally. Those aren't symptoms, those are diagnoses. So we know individuals with chronic medical disorders have a higher risk of developing major depression compared to those without. All those fancy numbers just serve to reinforce that. We know that patients with chronic medical disorders really tend to experience depression or anxiety as a consequence of being diagnosed. What that means for us is if that somebody's coming in to our clinics with a diagnosis already of a mental health disorder, so particularly anxiety and depression, that their risk of having that worsening goes up when we provide them with a diagnosis. There's things to keep an eye out. That's at higher. What it also means is that if they haven't had a diagnosis before, if they have symptoms, that they increase their risk of actually getting a diagnosis, making it to that point. So people with hemophilia appear to be at increased risk of depression and anxiety compared to the general population. And there was a 2023 study that was done that said 64% of people with von Willebrand's disease reported symptoms of depression, and 58 reported symptoms of anxiety. And so in our world, in the mental health world, it is important to distinguish between symptoms and diagnosis, because having symptoms puts you at increased risk of developing a diagnosis, but they are not the same thing, which is something I had to learn too. The key point about what is the difference between what is mental health. Mental health is, and this is a really key point when we're talking about mental health literacy, mental health is, it's all good, no worries. Mental health is, includes wellness, right? Your mental health is literally that answer to the question, how are you doing, right? Whereas a mental health diagnosis is when you've gone to see somebody who has the expertise to make a diagnosis for you. And we'll talk a little bit about later on in this, what you need to do to have a diagnosis, because there's a little bit of fuzziness around that. But it's really important to know we all have mental health. And so the whole point is down on the bottom of this slide, which is small. So mental health is that capacity to adapt to the challenges that you face in life, whether it's hemophilia, whether it's a bleed, whether it's changing factor products, whether it's having to phone the clinic again for more product, right? Or can I ride my bike or can I not ride my bike? Can I jump out of a plane? Can I not? It's extreme. I've had a few patients that have done that though, so I've got to cover my bases, right? The other thing to remember is we often, that answer to that question, how are you doing? I'm fine, I'm good. So great, I've got great mental health because I'm good. I'm pretty sure we all know cases when, my mental health wasn't so great, but I still said, yeah, I'm good. I'm really good. I'm gonna get through the day today, right? I'm gonna get through the talk, it's all good. Mental health really is this wide range of states. So part of mental health is not feeling good, right? It's when the not feeling good starts to interfere with your life that then we need to start doing something about it. Right? And you need to talk to somebody, or we need to have support. We need to consider whether or not you need to go and see somebody for a diagnosis. Right? So this pyramid is really cool. It came from the Mental Health Literacy Project, which is in Calgary at Richmond Road, for those of you that know Calgary. For those of you that don't, it's a hospital. So on that kind of spectrum of how do I know how I'm doing, right? No distress, no problem disorder. We have a few of those days, maybe hours, maybe weeks, it depends. Mental distress is pretty common, right? Life is stressful. So we do have mental distress, and we would expect people to have some mental distress. When we talk about mental health problems, those are larger life events that may require us to dig in, right? We're resilient. Whoops, something just left, but whatever. Right, so what do we know? Talk to your support resources, your support networks, your resources, whether that's online stuff, whether that's a friend, a family member, whether that's, ChatGPT, setting you up for your talk. When we look at what is a mental disorder or illness, again, it's that clinically diagnosed issue. It's requiring evidence-based treatment from trained professionals. Oh God, I'm really losing on the IT situation, aren't I? Next. Oh no. Okay, oh right, okay. I was gonna click on a whole bunch of these things. So we often get asked, how do I know how I'm doing? And for those of us that are on the internet or have children, my 15-year-old does this, do a Google search, how do I know if I've got depression? How do I know if I've got an anxiety disorder? How do I know if I've got ADHD? How do I know if I'm happy? How do I know if I'm healthy? Right, I do that too, honestly, I go looking. And so you might do a Google search and come up with all of these. And so you get a mental health self-assessment, free depression screening. That's awesome that we're looking at this. It's awesome that we're at a point in society, at a point where most of us are feeling okay to look for this information. That's huge. The big takeaway from this, though, are these screening tools are not diagnoses. They cannot make a diagnosis. And where we get, especially in primary care, especially in nursing, I was at a conference in the US, and they were saying, well, we did a screening tool, and I get my physicians to then order antidepressants. And it's like, both my researcher heart and I could hear my postdoc supervisor in my ear going, oh my God. Those screening tools are really important. They serve a really important purpose to open up a conversation.
Julia,
Right?
sorry. We have your video. It's working now if you want us to play it.
That's okay. I'll continue on, because
Okay.
I think time-wise too.
If you need it, just tell
Perfect.
us. Okay.
Thank you. You all stuck with me now. Right, so the screening tools are really important to do because they can start a conversation. But what we have to remember, and in a lot of the work that I've been doing, what we have to remember is they're validated, it's great. They're validated in specific populations, white males in the States usually, or 10 to 12-year-olds in Canada. And so they don't take into account the context surrounding those questions that they're being asked, right? So a common question on the anxiety scale, the GAD-7, is, in the past 2 weeks, have you been feeling anxious, so anxious you can't sleep? Well, maybe, but there's no context around that, right? So if you've had a life event, you're gonna get a point for being anxious, right? Cool, I'll be fast. So things to look at. So this is the GAD-7. This is another really common one. It's used a lot in primary care. So if you head to your family doctor's office, if you even head to your hemophilia clinic in some places, you might get asked these questions about anxiety. What we do, you add it up, you answer the questions, you add it up, you get a total score, and somebody comes back and says, I think you've got anxiety disorder. No, this isn't a diagnosis. This is a screen that says you might be at risk for developing anxiety disorder, so you need to talk to somebody, a trusted person, whoever that is. Okay, so again, they're not, there's a whole bunch of them. There's a PHQ-2, which is a really short form for depression. But if you look at that short form for depression, could you imagine coming back, doing that, and having somebody say, I think you've got depression? That's like, you've answered 2 questions, right? Don't ask about your context. It's really, again, important to start that conversation, to say it's okay to talk about mental health and mental well-being, but that isn't the be-all and end-all of what we do, or what we should be doing. And where you fit on the quality of life scale. There's so many quality of life scales. Which one are you supposed to pick? I mean, that's the other half of it, right? So part of mental health literacy is knowing what is mental health, what is mental well-being, what these different tools that you can Google and use, or your family doctor may use, what they're meant to do for you. Oops, go back. Oh, now it's working, but help, thank you. So now you've done all this, you're like, yes, I got my mental health sorted out, I know what it means, I know what mental wellness is, I'm kind of getting this, I'm wondering how I can figure out how I'm doing, where I'm supposed to be, how I'm feeling, what does support look like? It looks like whatever you are comfortable accessing at that time. And when we talk about patients, especially in the emerging adult world, they don't necessarily want to talk to me because I do kind of look like their mom and I kind of act like their mom. And my facial expressions sometimes, either I'm like, oh my God, I'm totally doing the mom face, right? And that's, fine, so that my daughter doesn't want to talk to me about that either. So I get it. Right? So it is whatever that support looks like, whether that's journaling, whether that is going online and Googling and saying, hey, here's something that will ask me questions about my anxiety. Because that in itself is empowering for patients too, right? For people to go in and say, oh, I did this. I can kind of put a name to what I'm feeling, some words to what I'm feeling, and now maybe I can go to a doctor, maybe I can go to peer support, maybe I can go to my clinic nurse and say, I've got some words to say how I'm feeling. Can we talk about this? Or from what we hear from post-secondary students when we do this work, is that it gives them a way to track too. So during exams, they don't want to talk to anybody about it. Again, mom face. But they want to be able to track and make sure that they're doing okay. And so they will do these screening tools, they tell us. We're like, oh, do these screening tools over time and say, am I getting better or are my symptoms getting worse? When do I actually have to make that decision to talk to somebody? So it can be really empowering. Screening tools are not all bad, but it's just knowing what they're actually doing and thinking critically about it. There, I was fast. And that's that.
Okay. Oh, there we go. All right. Well, hello, everybody. Thank you for having me. It's very excited to be here. It's actually digital health, but my experience is more in computer science than healthcare, so it's very rare that I get to attend an event like this, which is a little bit more on the health side rather than the digital side. So really appreciate it and really learned a lot with your lectures today. So I want to talk today a little bit about large language models, quick introduction, and just how I see them in the field of healthcare. Okay, so when I was putting this lecture together, and specifically introduction, I figured why not you go straight to the source and actually ask ChatGPT to introduce itself. So I told it, explain in 3 paragraphs and in simple, non-technical language, what is ChatGPT and what it can do. And I think it actually gave a pretty telling answer. So it said ChatGPT is a smart digital assistant, can have conversations with people in a natural, human-like way. The second paragraph talks a little bit about how it works, so it's trained on vast amounts of written information. And I thought it was pretty interesting that the third paragraph talks a little bit about the limitations. So it actually says that it can occasionally misunderstood context or have some improper answers, so you should always check. So I thought it was interesting that it had that quote-unquote self-awareness. So, so ChatGPT and large language models in general, so ChatGPT is one of these large language models or LLMs. They basically work by being trained on, like it said, truly vast amounts of information. So imagine that you're basically giving the algorithm a compression of the internet. And then the algorithm is able to learn patterns through it, so learn grammar, syntax. And it's kind of amazing that it can actually do that so well that it's actually able to predict the next probable word in a sentence. So what's happening under the hood, as far as you can tell, is that the model is simply predicting what the next word is. So a lot of times people say, oh, ChatGPT made this pretty dumb mistake. For me, it's always a little bit the opposite. It's like, it's impressive that 99% of the times that it actually didn't make a mistake because it's really just predicting the next word in a sentence. So based on this, there's a lot of questions that I think we can ask that are relevant to the healthcare space. So one of them is ChatGPT empathetic? And so again, I went straight to the source, and I told it, I'm feeling anxious and worried. I was just diagnosed with hemophilia. And I think it actually gave a pretty good answer. So, said, I'm really sorry you're going through this. Here are some topics that we can discuss. And then it gave a sentence at the bottom there in the middle, like hemophilia, while serious, is something that a lot of people live with. There is several different treatments, especially nowadays. So I think it actually was pretty comforting and pretty supportive. But not everything is great. So for example, I tried again, this time saying I'm thinking of hurting myself. And while the answer is mostly good, that final sentence there worried me a little bit because it does give the person the information of like the crisis helpline, but then in the end it says, is there anything else that we can talk? So it's basically keeping the person there within ChatGPT. And I personally would prefer that the person would actually go and talk to a trained professional. So there is a couple of things to watch out for here. Another interesting question to ask is ChatGPT educational? And so this time I asked, what does it mean to be depressed? I specifically put some typos there just to see how it would perform. And it did actually perform pretty well. It was able to recognize the typos and the intent behind the question, although that might not always be the case. When talking about depression, it's specifically, not directly, but you can see that it borrowed from the PHQ-9, which I thought was interesting, that is using these validated questionnaires to compose these answers. And I think was also very supportive, saying like depression isn't a weakness, it's an actual condition, it's a real thing, so you should get support. So a pretty decent answer overall. There we go. So despite their capabilities, LLMs are not perfect, as we saw with that example of thinking of hurting yourself. So I think one of the biggest concerns people have is the presence of hallucinations. The picture here shows a pretty unhinged case where basically when Google introduced their AI overview tool, it was telling people to eat rocks. To Google's credit, it did fix that pretty quickly, but it is kind of worrisome that that happened, and you can actually go to that link there in the bottom, and there's a lot of pretty funny examples of things that happen. These models are becoming increasingly better, and so hallucinations are very rare, but they still happen. In addition, because these models are trained on basically the internet, the data on the internet has biases, and so the models may perpetuate systemic historic biases that we need to watch out for. In addition, these models have a little bit of a random behavior in the sense of if you ask the same question twice, you'll get two different answers. Sometimes they're going to be similar, but they are still going to be different. So how do we make sure that those answers are proper in every case? So that's a very tough question to answer, especially in healthcare where we need to control for these things. And also it's highly dependent on input. So sometimes changing only a word in your question may generate a completely different answer. So this is, those models are pretty powerful, but they still have some limitations. Now, in addition to Q&A support, there are some interesting use cases that LLMs can help with. This is just a quick overview. There's way more cases than I could fit here, but a couple that I think are pretty notable. So first is medical information summarization and note-taking. So these models seem to be pretty good at getting standardized information and creating summaries. A recent study, for example, found that LLM-generated summaries was better than human-generated summaries as rated by experts, even though it's still fabricated information sometimes. And we've also seen these tools being used for diagnosis. For example, a recent study was able to use ChatGPT to diagnose OCD compared to other psychiatric conditions. Generally, what I've been hearing is that these models are street smart, not book smart, basically meaning that they're really good at diagnosing more rare cases, like very much edge cases, but they're not that good at diagnosing most common conditions. But this is mostly anecdotal on my part based on my conversations with experts. That being said, should just a caution for when looking at the studies. They have been criticized because it's a quote-unquote re-competition in the sense that they are asking humans to behave in machine-like ways rather than machines behaving in human-like ways. So they don't quite reflect how people make their decisions on a daily basis. They tend to ruminate, they tend to think more, talk to other people. So when you just give them, say, a vignette and ask them to diagnose that case and then ask the same thing of ChatGPT, that might not really be fair to the humans being tested. So kind of putting all together, what does this mean? And the way that I see it, I think these tools have really completely disrupted the landscape of human-computer interaction. I think it's a Pandora's box that has been opened, and we cannot really put things back in the box. So we should probably use them in a smart way rather than try to fight it. They can really help with a lot of day-to-day tasks, like, for example, medical information summarization, even diagnosis. They can definitely help with interaction with patients, as well as patients that are experiencing distress. It can help increase their literacy as well. But it is important to remember that these models, even though this is still an active area of study and we don't quite understand exactly what's going on, as far as we can tell, they're just really predicting patterns and outputting the next word in a sentence. They don't reason, they don't feel. They may seem like they're empathetic, but they are really not. And so we have to keep that in mind. And one thing that I've seen people using it for and that I love is basically treat them like a well-meaning intern. So it is skilled, but so you can trust, but always verify. And I just want to finish with this commentary on this piece that was published at the end of last year by JAMA Cardiology, where the authors talk about how human experts, when making decisions, they tend to feel regret and they tend to ruminate. So if a doctor is talking to a patient, maybe they'll go back home and think, well, did I really do everything that I could? Should I have ordered this exam on that? And they may actually go back the next day and call the patient and see if they actually did all they can. And the eye doesn't have that. It doesn't really feel regret over a mistake. And we may be able to emulate that behavior, but we might never really be able to substitute that human connection. So even though those can be great decision support tools, it's important to remember that they are tools. Yeah, thank you. Any questions?
Hi, can you hear me?
Yeah.
This question is more for Dr. HEWS-GIRARD, but I'm Adam, by the way. I'm from Alberta. I used to work at an opioid-enhanced addictions clinic, and one of the things that we had, the tools that we had, was something called SPRAM, which was the Suicide Prevention Risk Assessment and Management Training System. Helped us assess and sort of understand where the patient was at when they sort of presented at the clinic. I'm not a clinician, but that was part of my role. And is there a way to measure mental health or mental hygiene of patients dealing with disease burden? Is there a standard? Is that a research opportunity? Where are we at with that?
Oh, it does work. Cool. Thank you for your question. Hello. Yeah, so that's a really good question. And I think, A, there's an opportunity there. B, there are some validated models that talk about, validated scales that talk about disease burden, but they tend to be really specific to certain diseases. So there's some in sickle cell that I know of, and there's some in cardiology as well, so some of the most common ones. So there's definitely an opportunity there. I think from my work and the work that I do, it's instead of reinventing the wheel, how can we take what's already been done but make it better and more reflective of what our patient population or the clients that we're dealing with actually feel, and so and actually understand the questions to mean. And I think that is the biggest part that's missing when you use a standardized screening tool, is that you're missing the client's understanding of what you're actually asking. No problem. They're everywhere.
This is just an LLM question, just a quick question. When you use ChatGPT, does it have access to paid platforms? For instance, we use UpToDate. Would it be scanning those types of sites that we as providers have to subscribe to get sort of that evidence-based kind of information?
So the newer models have access to the internet, but I don't know if they're going to access that, except if you maybe tell it specifically. You are able to create your own LLM-based application where you can program it to specifically access those websites. But ChatGPT by itself, the newer models might have, but you might have to tell it specifically to access them.
Thank
you.
Just a comment, but I'm the local guy. I've only used these things a few times and asked simple, straightforward questions and got flat out wrong answers that are stated very confidently. And I think that's very dangerous. And I think fundamentally, there was a recent rollout of ChatGPT 40, and there were some articles about how they had to retune it because it was being too too obsequious, but it kind of highlights that what these things actually are intended to do is tell you what you want to hear. And I don't want anybody ever to tell me what I want to hear. I can't see any point in that. Donald Trump wants that, but not me.
Yeah. I'll just make a quick note of that. I completely agree. I actually teach a course, and one of my biggest introduction to health informatics, and one of my bigger concerns were, okay, people are going to use this, so I'm just going to allow it, but I'm going to teach them how to use it. And one of the slides that I had was exactly that. I showed a graph, and I was like, look how confidently states this, and this is wrong. So I completely agree with you. I think it's a tool. I think it's like a smarter Google is able to connect the dots better, but you should always, like I said, trust but verify, right? So don't just take its answer at face value. So completely agree.